Hello, everybody. Thank you so much for being here today. Um, I have been excited about this talk for quite a few months now since Shaun agreed to do it. I've heard Shaun speak before at a training day on trauma-informed palliative care last June, I think it was, in Oxford, and it was wonderful. And I know that today he's bringing some even more of his insights. So I'm really looking forward to that. Shaun does a lot of everything, from what I can see. So he's a palliative care physician at Oxford University Hospitals. But alongside that, he's also a researcher and an educator. Apart from working as a research fellow at the Centre for the Art of Living and Dying Well, he also was awarded a Churchill Fellowship a couple of years ago to travel to Canada and the US to learn from their models of palliative care. And as a result of that, he's written up a very uh, detailed and well-structured report, which he's going to share some of those findings from today. So thank you and welcome, Shaun, and I'll hand it over to you.
Thank you, Bex. That was very kind. Can you hear me okay? Yeah, it was also especially kind for you to find a diplomatic way of saying my very long report. But yeah, I appreciate that. So nice to see everyone. I will just try sharing my screen now so I can get my slides up. Okay. Can you see that okay?
Yes. Yep.
Great, thank you. I can't see anyone now. So if there's any issues with my slides or anything while I'm talking, can someone please speak up just so I know? But that's great. So, like Beck said, my name's Shaun. I'm a palliative care doctor in Oxford, and I've been asked to speak today about lessons from my Churchill Fellowship research, which I undertook in 2023, about trauma-informed palliative care for vulnerable and neglected patient groups. And I'm aware that there's a lot of experience and expertise in the webinar today. And I hope it doesn't come across too much like I'm trying to teach you to suck eggs here, because I'm sure there's people who know a lot more about these topics than I do. But it's really useful for me to be here as well. And hopefully when we get to the discussion, for me to learn from all of you. So yeah, I appreciate that. I appreciate being asked to be here. What I'm planning to speak about is just an overview of kind of how I've conceptualized trauma and palliative care, and then trauma-informed palliative care for the purposes of this project. And then a little about the particular structurally vulnerable groups that I chose to focus on with this research: people experiencing homelessness and people in prison, and why I thought those were important groups to focus on. I'll explain a little bit about what I did with my Churchill Fellowship research, and then highlight some of the recommendations in the report that I've generated, and then talk about my hopes for the future in this area, and hopefully have time for discussion at the end, because I would appreciate to hear what you think. Um, Unfortunately, I know that having an interactive webinar is ideal. Unfortunately, because of the way my brain works, it's actually easier for me if I can just get through my slides and then have time for questions at the end. Hope that's okay with everyone. So to start off with, to talk about trauma, um, traumatic experiences are those which are overwhelming and unacceptably threaten a person's physical or psychological or social well-being or safety, leading to lasting neurobiological changes. And survivors of trauma, traumatized people, have a whole spectrum of negative consequences which they can experience throughout the rest of their lives, including higher risks of further harm, substance use, mental illness, preventable disease, early death, educational difficulties, contact with the criminal justice system, and overall reduced opportunities in life. And I guess for me as a medical doctor, I know that doctors are often very focused on kind of how is this medical, how is this, can this be a diagnosis? And I think for us, our minds might often immediately go to post-traumatic stress disorder, PTSD. But I think what's important to remember is that the diagnostic criteria for PTSD is actually very specific, and the vast majority of traumatized people do not meet that criteria. So, in other words, most traumatized people do not go on to have PTSD, but they are still traumatized. So, when we're thinking about trauma here, yes, that does include PTSD, but we're speaking about something much broader than that. So why do I think that trauma is so important in palliative care? Well, there's three main reasons. So generally speaking, trauma is extremely common in the general population, including those who are inevitably also accessing palliative care. So, for example, at least half of people in England and Wales have experienced a significant adverse childhood experience, and about 10% have experienced four or more ACEs. Second main reason is if we think about the patient journey of a person who has a life-limiting illness, and the things which are involved in that patient journey can themselves be traumatizing or re-traumatizing. And I think some of these are maybe probably easier for us to remember. So if we think about things which might be more obvious to us, like people being expected to expose their body, have intimate examinations or invasive procedures, and perhaps also just think about challenging and confronting communication. But there are also aspects which are maybe more intangible and less easy for us to remember as well, such as just the feelings of powerlessness about a situation, or powerlessness in a kind of a healthcare professional patient interaction, especially if the person's views are disregarded. And the third main reason, which I think that trauma is so important for us to care about in palliative care, is because of equity. And what's well documented is that structurally vulnerable groups of patients are those who are most underserved and neglected by the current provision of UK palliative care, including people from racialized minorities, those living in poverty, experiencing homelessness, or people who are in prison. And there's lots of will and lots of discourse out there about how we need to improve palliative care for these structurally vulnerable groups. And here, when I use the term structurally vulnerable, I'm being very deliberate in my use of language, because I think to just describe someone simply as vulnerable kind of suggests that that's almost an innate state of being, as in that's just the way it is, that's just the way it has to be. But actually, if we emphasize the fact that people are rendered vulnerable because of the systems, hierarchies, and other hegemonic power structures that exist, it helps us to remember that this isn't just the way it has to be, and it reminds us to criticize the structures that cause people to be vulnerable in the first place. So, um, why then do I think we should focus on trauma for as an equity point of view, as an equity in order to advance equity? Well, these marginalized groups we're talking about are more likely to have experienced significant trauma. And therefore, by enhancing palliative care, enhancing trauma-informed palliative care, we can thereby use that as a point of focus to make palliative care more equitable for these patients. I think this is important for all structurally vulnerable groups, but I, in particular, for the purposes of this project, because of the limitations of time and funding, had to kind of narrow down and focus, narrow my focus. And so I have chosen to, for this project, to focus on two particular groups for whom UK palliative care should be improved, and that's people experiencing homelessness and people who are in prison. So to explain a little bit of context about why these patient groups are so important for us to think about in palliative care, we know that across the board, homelessness is extremely bad for your physical and mental health. These are just some metrics: far greater risk of hepatitis, suicide, poisoning, drug overdose, violence, much higher rate of death than the general population. But these are just a handful of metrics. If you look at basically anything, homelessness leads to much worse outcomes. And if we think about in Scotland, where I come from, the average age of death for people experiencing homelessness is 39 for a homeless woman and 43 for a homeless man. And on the other hand, stable housing and reliable access to healthcare actually um, can lead to much better health outcomes and reduce the risk of premature death. So I believe for the perspective that I took for this research was that homelessness is in itself both a life-threatening and a life-limiting condition, and therefore something that palliative care practitioners should care about. However, there are well-documented challenges in providing palliative care to people who are experiencing homelessness. There's many barriers, and this includes the difficulty in identifying homeless people who may have palliative care needs. The so-called roller coaster trajectory may make it seem that someone can look extremely unwell one week and then by the next week they've maybe bounced back and rallied, making it difficult to know at what point palliative care should be involved in that person's care. There may also be lack of knowledge, just or awareness among homelessness services, and those who have more interaction with homeless people about palliative care and how to access it. And then there's issues around how our specialist palliative care services are organised, are relying on referrals from other services instead of accessing patients directly. And maybe professional risk assessment or stigma. Um, Healthcare professionals might feel I don't want to go into that environment because there may be you know syringes or needles, for example, and that perception might be accurate, or it could also it could be a false perception as well. And we know that homeless people often don't seek healthcare, or when they do, it's often at a point of crisis. And ultimately, that really there are ultimately a lack of options often for providing palliative care for people who are homeless. So even if actually they're referred, we identify that they have palliative care needs, we get to know about them, actually often there's nowhere to send them. So these are the kind of barriers for palliative care for people experiencing homelessness that I um, concentrated on and was cognizant of as I went on to develop the rest of my research. And for some context about the situation for people who are in prison, we think about the UK is the closest to the United States in all out of European countries in terms of its um, approach to incarceration and punitive sentencing. The UK generally imprisons people at a higher rate than any other Western European country, and the number of people in prison in the UK is increasing despite the fact that crime is reducing. And just to give some kind of contextual demographics, we know that 95% of prisoners are male. Black and minority ethnic people are overrepresented in the prison population. About a third of prisoners have some level of intellectual disability, but the vast majority have a poor level of educational attainment. And people who go to prison are more likely to have suffered social exclusion compared to the general population. And the proportion of the oldest prisoners has been increasing over time as well. So likewise, being in prison is incredibly bad for your health. Prisoners have a biological age at least 10 years above their chronological age and a lower life expectancy. So the average age for a prisoner of death of a prisoner in England is 56. And they have a mortality rate higher than the general population. So there are significant health needs and palliative care needs in prison. And we know that from both our national laws and regulations and international policy, that the standard of healthcare, including palliative care, that should be given to prisoners is should be the same as what should be expected by anyone else. So, for example, this this statement is from the United Nations Standard for the Minimum Rules for the treatment of prisoners, also known as the Mandela Rules. Prisoners should enjoy the same standards of healthcare that are available in the community and should have access to necessary healthcare services free of charge without discrimination on the grounds of their legal status. So we can extrapolate from these principles, which can also be found in UK documentation, that people in prison should also have access to high quality palliative care. However, research shows that anything but is the case. So, and the care of people in prison falls far below the standard that we would normally expect. And similarly, when thinking about this, I took into account what barriers have been established for palliative care in prison. And there's multiple, but it includes things like lack of resources, like medication, equipment, hospital beds in a prison environment, the architecture and design itself being unsuitable for an aging prison population, for people with mobility difficulties, for providing patient care. The fact that a compassionate release at the end of life is often denied in the UK. It's lack of working relationships between prisons and hospices seems very variable across the UK, meaning that specialist palliative care staff may not be granted access. And similar to people who work in the homelessness sector, people who work in the prison sector may just not be aware of palliative care and what hospice services can offer, and the fact that prisoners have the same right to access palliative care as anyone else. And although I've spoken about how I'm focusing on these groups, they're not totally mutually exclusive. I think there is a lot of overlap. So, for example, a significant number of people who are homeless have been in prison or have had contact with the criminal justice system. And I think a useful concept to think about when we think about the kind of overlapping structural vulnerabilities is that of multiple exclusion homelessness, which is the deep social exclusion of those affected by homelessness, plus institutional care, substance use, and or involvement in street culture activities. And um, people who have experienced multiple exclusion homelessness are much more likely to have experienced trauma as a child. So at least 85% have experienced adverse childhood experiences. Okay, so now moving on to what I mean by trauma-informed care. So I suppose uh, the view that I took was that trauma-informed care was about integrating knowledge about trauma into policies, procedures, and practices in order to resist re-traumatization and move from thinking what is wrong with you to what happened to you. And I did take on board the six principles, SAMHSA's six principles for organizations about trauma-informed care, safety within organizations for staff and the people served, trustworthiness and transparency to build and maintain trust, peer support with individuals with lived experience of trauma, collaboration and mutuality to reduce power disparities, empowerment, voice, and choice across an organization, and sensitivity to cultural, historical, and gender issues. Um, I know there's different perspectives on this. People have different opinions about it. I took the perspective that trauma-informed care approaches do not require disclosure of trauma. And I actually think since I've been thinking about this area, since I've done this research in my clinical practice, I probably actually directly ask my patients less about the adverse experiences that they have had earlier in their life. On reflection of experiences I've had throughout my career, I think that can often be very confronting and actually counterproductive to um, building and maintaining trust, to ask people to disclose their experience, their traumatic experiences. And actually, I don't think it is necessary for us to provide trauma-informed care for us to know whether or not that person has experienced trauma or not, and to know what the nature of that trauma is. And that if once you have built that relationship through providing the trauma-informed care, often the person will, when they trust you enough, will volunteer that information anyway. But that's the approach that I've taken for this project. I also always make clear that when I speak about trauma-informed care, I'm not talking about trauma treatment. And I guess one of the ways to kind of put this differently would be to think about kind of the way involvement and trying to help people who've experienced psychological trauma can be stratified in different ways. So this is one way, which comes from NHS Education for Scotland, to think about different levels of intensity of practice. So I'm putting being trauma informed at really the most basic level, which is a level which should be relevant to all workers, up to the next level up, which is more intense, which is trauma skilled, which is when you have more direct and substantial contact with individuals affected by traumatic events, up to the next level of trauma enhanced, where you have more regular and intense contact yet again, and then ultimately up to a trauma specialist who uses psychological therapies to try to help treat the trauma that's present in individuals who've been affected. So I what I'm advocating for here is that really talking about the most basic level according to this framework, this way of looking at things. Really think it's important that none of us, and I very much include myself in this, none of us kind of presume to be able to treat someone's underlying trauma unless we happen to have the particular skills, qualifications, expertise in that area. That's not what I'm advocating for here. I'm advocating for us to have this basic level of trauma-informed practice, which we can all, I hope, all be part of, even without having further expertise or being an expert in this area. And I'm certainly not an expert. And I suppose something else which I think is important for me when I'm thinking about being trauma-informed is, I guess, thinking about actually what are what as I've alluded to, kind of what are the structural factors that have led to people being vulnerable in the first place and traumatized in the first place. And I find this a useful kind of infographic to look at, and also a useful quote from Archbishop Desmond Tutu to think about. We need to stop just pulling people out of the river. Some of us need to go upstream and find out why they're falling in. And, I think about kind of my career in the NHS so far. I mean, I've been um, training or working in the NHS in some capacity or another for more than 20 years. And I think over the course of my career, I have seen so many different kinds of innovations come in, which seem to be, quite thought-provoking or even iconoclastic. Um, and actually, they end up really just kind of being kind of dismissed or reduced to their bare bones, and often things kind of just some things, it doesn't end up being as revolutionary as you think it's going to be, and you end up just, for example, say, oh, let's just add another tick box, or let's just add another pro forma to our admission documentation at this hospital, and therefore we've handled that issue, and we can say in our CQC report, oh, this is all sorted now, we've addressed this. So I don't think that trauma informed care, I'm not being prescriptive about in this work with what it looks like, but and what form it should take. However, I do feel that what I'm talking about something bigger here than just making superficial changes. And what I am interested in is actually how can we be critical of the structures that cause people to fall into the river in the first place, and how can we actually um, change the way we organize ourselves, the way things are structured. How can we do things differently at a substantial level, um, and not just accept that things just have to stay the way they are. So with all that background context in mind, I defined the aim of developing recommendations for inclusive, trauma-informed palliative care for people experiencing marginalisation in the UK through learning from care delivery elsewhere in the world. I successfully obtained funding for this project from the Churchill Fellowship, who funded me to visit the USA and Canada for 6 weeks, during which time I visited and learned from practice at 6 centres of care, um, including palliative care, for marginalised patients with a particular focus on people in prison and people experiencing homelessness. From my observations and my learning over the course of the fellowship, I developed, extrapolated what I'd seen and reflected on in the context of the UK palliative care setting, which is what I know and where I practice and where I want to make change, and use this to develop 10 recommendations for the UK for trauma-informed palliative care, and with a focus on equity and social justice. And as I've described, I do think that trauma-informed care requires more than just individuals to be aware or informed. I really was thinking about recommendations which focus on systemic change in how care can be provided in how care provision is structured and organized in order to make a whole trauma-informed system. So the 10 recommendations that I developed are written about in detail in my report. I'll just summarize them here. Recommendation 1, early contact and persistency to meet people where they are. 2, peer-to-peer care and support. 3, prioritize housing as healthcare. 4, adopt a harm reduction approach to substance use. 5, embed mental health care in palliative care. 6, utilize resources wisely. 7, cultivate a place of peace. 8, accept dying is different for every person. 9, acknowledge and share grief. And 10, unlearning and change in the professional team and within organizations. And you will be pleased to know, I'm sure, that I'm not going to go into detail about all 10 recommendations today. What I am, if I can get, sorry, just bear with me. What I am going to do is just touch on 5 of these recommendations to give you an idea of the kind of things that I'm talking about, and the kind of recommendations that I've come to as a result of my research. So early contact and persistency. So this speaks to when we think about actually the journey that a patient has to go on, often to end up being seen in palliative care services, and how that person has to be able to behave and manage themselves. A person has to be able to keep and maintain appointments, often several appointments distributed over time before they can even get into a palliative care service. Person has to be able to prioritize their own chronic health needs over more immediate urgent needs, which may be for food or shelter or drugs. They have to be able to manage their own behavior in a way that's seen as socially acceptable. You know, there's lots of things that some people have to do, which may be just bread and butter and obvious to people with more stable lifestyles. But actually, for someone who is experiencing significant trauma, they may render it extremely difficult or impossible for them to actually end up seeing someone who works in palliative care. And this is part of why people from structurally vulnerable groups actually may only become known to us at times of crisis, when it's often late, or we don't end up meeting them at all, even up to the point that they die. And this is despite the fact that in order to make a difference, we know that palliative care should be an early intervention in order to make a positive difference in people's lives. So I have recommended then that we take an approach to palliative care which and being trauma informed therefore involves being proactive, having a low barrier to access, and being the ones to actually initiate contact with patients. And what I saw in particularly in Canada, were palliative care community teams where literally there'd be community nurses, community doctors in the t-shirt and jeans with a backpack on their back, literally going out on the street, meeting people, going into shelters, meeting people, getting their faces and their names known, and actually being the ones to identify people who have or may have significant health needs. And although it's difficult for traumatized people to build trusting relationships, actually by being persistent, by showing up, and by actually getting your name and your face known within a community, can help people to trust more, to and to get yourself known as a safe person. This next recommendation is related to peer-to-peer care and support, where trauma-informed palliative care should be influenced by and informed by people from the same marginalized community. And the benefits of this are that there's shared experiences and understanding of trauma, shared cultural experiences and history. And this can lead to someone, sorry, I've just had a pop-up. Yeah, this can lead to increased acceptance of palliative care among people who would otherwise be mistrustful of it, increased trust in palliative care. And even if the person within, if we have peer workers who are members of our multidisciplinary teams, even if the only member of the MDT who a structurally vulnerable patient ends up trusting is the peer worker on the team, and that's still a positive. That's still an in to get that person the help and the care that they need. And peer workers are also invaluable for effective advocacy for patients, and being able to see things from their point of view and helping the rest of us not to be too paternalistic. Also very important that trauma-informed trauma-informed palliative care should itself not be exploitative and should be working against exploitation. And therefore, peer carers should be recognized and valued for their contribution to their work, and that includes through remuneration. This recommendation relates to cultivating a physical place of peace, a physical environment dedicated to fostering safety and healing. And during my fellowship, I saw this mainly in the form of gardens. So if I think about the example of having seen this at the California Medical Facility, which is a men's prison hospital in um, in California, in the hospice there has been a garden designed by residents at the prison for for use by um, prisoners, by patients in the hospice, by prisoners who are working as peer carers in the prison hospice, and by correctional staff, where people can sit together in the garden in a space where power disparities are reduced, where there can be a break from the rest of the prison environment, where in this space where there's no fear or reduced fear of discrimination, judgment, or criminalization. And actually, you think about for individuals who've been involved or been resident in prisons for years or even decades, how much of a guard they've had to put up and the things that they've experienced over that time, and the way that they might need to behave in other areas of the prison. But I actually saw that having this place of peace provided almost a kind of a place of normalization and healing, where they could take a break from all that and be just seen as seen like everyone else. This recommendation, I think, about accepting dying is different for every person. I think this is also useful for me, certainly as a doctor, and for my medical colleagues to think about in palliative care, because I think that we often have, maybe quite a paternalistic and quite a privileged view of, what death and dying should look like, what palliative care should look like. Imagine that actually everything's going to be wrapped up in a neat little bow, and all issues are going to be resolved, and we're going to get everyone's addictions to be resolved, etc. But actually, I think for us to be trauma informed and accepting of different people, we have to actually acknowledge that the behavior and wishes may not fit with our expectations. We have patients who never want to cease alcohol or drugs, even up to the day that they die. They may never want contact with biological relatives from which they're estranged. They may never want admission to a hospice or any other kind of healthcare institution. And we may never get to the stage where we've managed to sit down and have the serious talks with them and got them to accept the fact that they're dying and done all the advanced care planning that we like to do. And I think, one of the ways that this was put to me at my during my fellowship was that people who have chaotic lives often have chaotic deaths, and actually we're it's not always our role to go in and think that we can fix that so that someone's life and death can fit with what we want it to be. Actually, really, we should just accept the person that we're trying to care for and walk with them. And also thinking about what we think a lot about what matters to patients as they approach the end of life, but actually for people who have been marginalized, um, what matters to them might not be the kind of things that we're used to thinking about. It might be, you know, their focus might be what will happen to my belongings, who's going to look after my companion animal, who's going to remember me when I'm gone and be involved in my memorialization. Which brings me to the next recommendation that I was going to highlight today about acknowledging and sharing grief. I think this is important because generally unrecognized losses can have lasting detrimental effects on anybody. But for um, structurally vulnerable people, they are particularly at risk of disenfranchised grief, which is a loss that is not or cannot be openly acknowledged, publicly mourned, or socially supported. And for the kind of patients that kind of patient experiences that we're talking about, for example, things which may lead to disenfranchised grief could be the loss of someone from the same street community, the loss of someone from the same prison community, losses by suicide, deaths from AIDS, the loss of complicated grief, the loss of someone who has been violent against you, or the loss of someone who you have been violent towards. But complicated losses which can't be socially supported in the same way often go unacknowledged publicly. And marginalized people often have multiple losses, and there can be multiple episodes of disenfranchised grief over their life. So I do believe, when we think about it in this way, that grief and bereavement are not so separate from social justice issues, and a trauma-informed approach to grief and bereavement should acknowledge that these are not separate issues from poverty, homelessness, criminalization, or racism. So I think, again, I mean, I know I'm talking a lot about my experience as a doctor here, so forgive me from that. But certainly in my experience as a doctor working in palliative care, I don't know what it's like for if it's so much like this for other professionals, but so I'd be interested to hear about your experiences. But I think obviously we're around people who die all the time, and there is no space given, certainly not formally given, for acknowledging loss or grief, and we all kind of carry on regardless. And that is seen as being the professional way to behave, and actually to act differently would be seen as being unprofessional. So I mean, I don't necessarily think that that's right. That current way of being is right for anyone. But we think about what would therefore be trauma informed and why is it important for people experiencing marginalization for us to share in grief? Well, um, structurally vulnerable people have often been told and made to feel their whole lives that their lives do not matter. And actually, when it comes to asking people when they what matters to them and their response is who's going to remember me, I feel like if we carry on regardless, as if nothing's happened, no big deal, we just move on to the next task. Actually, what we're doing is we're confirming and we're participating in a system that acts like those lives do not matter. Furthermore, more selfishly, for ourselves as professionals in whatever capacity, we are at risk of vicarious trauma, and seeing these unjust losses, um, and the lack of recognition of grief around that is itself traumatizing to us. So our sharing in grief is a continuation of the care for the people who've been neglected by mainstream society. So I believe that both for our patients and for ourselves, we should be involved in acknowledging and sharing in grief. And this kind of, there's it's not one size fits all, but there's different ways that different shapes that this could take, including public mourning. And public mourning again does means different things at different times. Could include something more traditional like a memorial service, can include art displays, can include digital memorials like the Dying Homeless Project. And actually, I'd say that if we're motivated by our grief to make change, to go on activist marches or do social justice work, that also can be an expression of public mourning as well. And like the other recommendations that I've made here, like the other things I've spoken about, people from those marginalized communities, the people experiencing marginalization, should be involved in leading, celebrating the lives of the people who've been lost from within their own community. So that was just kind of a flavor of the kind of ideas that I've had, the ideas that are in my report. However, I know that other people might come to different conclusions from me, which I'd be happy to hear about, and learn from you. Um, I really believe that trauma-informed care cannot be prescriptive. I can't give someone a standard operating procedure on how to do trauma-informed care for their patients. And actually what needs to happen and what I really hope will happen is that people working in palliative care will think about these ideas, think about these principles, and how might they fit in with their local organizational structure, the context, the people that they serve. Maybe taking on one or more of these recommendations, or adapting the recommendations to work for them, or maybe just chucking my recommendations out but coming up with your own way of doing things. And I'm really hopeful and interested to see how these trauma-informed principles can be integrated into UK palliative care in the future. And I suppose linked to that, if I come back to my infographic and the concept of the structures that exist that render some people vulnerable and some people falling into the river, I guess I am very aware that I suppose everything that I've spoken about, and I guess everything that I feel that what's easier within reach is to be maybe like one of these folks who's trying to pull people out the river, or throwing someone, a buoy so that they can stay afloat. Um, but I think again, if you allow me to provide another quote, which I find useful for thinking about this, is from Martin Luther King's speech at the Riverside Church in New York, Beyond Vietnam, A Time to Break Silence. Dr. King said, on the one hand, we're called to play the Good Samaritan on life's roadside, but that will be only an initial act. One day we must come to see that the whole Jericho Road must be transformed so that men and women will not be constantly beaten and robbed as they make their journey on life's highway. True compassion is more than flinging a coin to a beggar. It comes to see that edifice which produces beggars needs restructuring. And I do believe that an edifice which produces beggars needs restructuring. And even though I guess what's probably within our grasp more immediately is to be more along the lines of um, flinging the coin to the beggar to kind of sorry, I'm really stretching this metaphor here, but I guess what I'm trying to say is being trauma informed is also, I suppose, working alongside thinking about people who are working at more kind of a public health policy, public palliative care level to be, yes, we work at the sharp end, at the deep end, trying to help people downstream, but also we should be working alongside and promoting people who are working at a more upstream level, thinking about our systems and societies and how we can stop people becoming structurally vulnerable and stopping people becoming traumatized in the first place. So to summarize what I've spoken about, I think that trauma is important for us to care about in palliative care because it's common in the general population, including people who are accessing palliative care services and people who have life-limiting illness, but especially among the most marginalised patients in society, who are also those who are currently underserved by UK palliative care. Trauma-informed palliative care is therefore an equity issue because it can improve accessibility and inclusivity of patients of palliative care to structurally vulnerable patients. And I've presented some of my learning from centers of excellence in trauma-informed care from North America and how that has informed these recommendations for integrating trauma-informed care in UK palliative care. And I am hopeful now that going forward, palliative care teams will consider how they can adapt the principles that we've spoken about to fit local organizational contexts and make things better for the people they serve. So these are my references and these are my contact details. And if you are interested, my full report is available open access online now. It's called Palliative and End of Life Care at the Deep End. As I alluded to, the report is quite long, but hopefully you can look at the contents page. It'll be accessible without having to read the full thing cover to cover. You can dip in and out of the parts which are maybe most relevant or most interesting to you. And also at the start of each recommendation chapter, I've just included a summary box as well. So I know that we're all short of time, so you don't need to read the whole thing. But anyway, hopefully that was okay, and I will stop sharing now.
Oh, thank you so very much, Shaun. That was really, really, really great.